أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم نحمده ونصلي على رسوله الكريم سبحان ربك رب العزة عما يصفون والسلام على المرسلين والحمد لله رب العالمين إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما صدق الله العلي العظيم. Dear all, Assalamu alaikum. Hope all of you are in good shape and must have got your elders vaccinated against COVID. Well, at present we are going through the drugs acting on autonomic nervous system. You know, autonomic nervous system drugs, they are very, very important, and it is heart of the pharmacology. All of you should have sound knowledge about the drugs acting on autonomic nervous system. While going through the previous lectures about it, I have seen that at good length about the autonomic nervous system, anatomy, physiology, they are well taught, and how the neurotransmitters they are synthesized, they are released, they are reuptaken like that. They are discussed at very good length. Then the cholinergic drugs, you have been taught about it, the directly acting, then indirectly acting, then reversible anticholinestases, irreversible anticholinergics, you have gone through that. So the part of pharmacology which is to be taught about the drugs which are known as anticholinergic. The name over here, it is anticholinergic. It means they will block the muscarinic receptors and also the nicotinic. But in general, when we say the anticholinergic, it means the anti-muscarinic anticholinergic drugs. Please note it down. When we say the anticholinergics, it generally means that these are the anti-muscarinic, anticholinergic drugs. So we have to discuss it today. Very important part of that, and very important drugs. Prototype, you should go through it. And before that, if you have sound knowledge about the receptors, where lie the muscarinic receptors, what are the types of muscarinic receptors, and how the second messengers they act, so it would be easier for you to follow it. You know the two main systems, the parasympathetic system and the sympathetic system, they go side by side. If one side is suppressed, the upper will take upper hand, the other will take upper hand. So we go through different slides over here and we will discuss it. At the same time, I will ask my students to have a pen and a pencil and a copy. So number of things not discussed, they are not displayed over here. They should note in their notebooks. That may be asked later on. So coming to this slide, you see what you are supposed to know about the drugs, about the cholinergic drugs. As you have been told, over here it means the anti-muscarinic, anticholinergic. Anti-muscarinic, that's a competitive system. These drugs, they compete with acetylcholine at the cholinergic receptors. You know, M1, M2, 3 like that. So we will discuss this later on. So how to classify anticholinergic drugs? You know that drugs are classified differently at various places. So drugs are classified according to the route of administration. Drugs are classified according to the duration of action. Drugs are classified according to the mechanism of action. A number of different ways are there. There may be therapeutic classification. Over here, among these anti-muscarinic, anticholinergic drugs, the therapeutic classification or clinical classification that is given more importance. Next thing, what you are supposed to know, you should be able to write the pharmacological actions of atropine. Atropine, just concentrate on this atropine. A well-known drug, and it has got very good history of say 200 years, rather more than that. I was going through literature that one well-known uh, well-known personality, Cleopatra, she used this atropine in before at the end of the that BC, before Christ. So she used it, atropine, just to dilate the pupil, and it was considered that if the pupil is dilated, the lady will be more attractive. So atropine, it has gone. It is crystalline form that was around in 1901. I was going through that. So atropine, you just concentrate over here. It is tertiary amine. Note down, tertiary amine. There are certain quaternary amine. Atropine is tertiary amine. So it will cross the blood-brain barrier. It is lipid-soluble and it has wide effect. There is no selectivity. It passes through the membranes and so it has got widespread effect on the body. Say like on the higher CNS, on the eyes, then on the GIT system, then on the glands, on the heart, genitourinary system. So it has got very wide effects, the pharmacological actions. Then third one, the well-known clinical application should be there in mind because this is well-tested drug. It has good history of say more than around 200 years, more than that rather. So its a clinical application, clinical uses, they are also very important. At the same time, where it should not be given, contraindication, note down. When not to be given this atropine or the atropine like drug. The effect anti-muscarinic, anticholinergics, they are related to atropine in general, but certain other drugs they also have anti-muscarinic or atropine-like effects, like antihistamines, antipsychotics, and this kind of drugs you will study later on. Then, well known at the end, at the lower side, you see the toxicity. Atropine, not only here you will study in pharmacology, you will also study in toxicology, in forensic medicine, in detail, and how to treat the overdose toxicity otherwise. Atropine is something very toxic drug, very toxic, lethal. So very small dose is there, say around 0.25 milligram or 0.5 milligram. So it's something very important to use it, where to use and where not to use, and if there is toxicity, how you will manage it. The next one. Here classification is given. One is the anti-muscarinic and the anti-nicotinic. Anti-nicotinic, let it be in your mind that where lie the nicotinic receptors. Again, please note it down. The location of nicotinic receptors should be there in your mind. And then the location of muscarinic receptors, you have also studied the M1, M2, M3 like that. So let their location and how the effect will be there, the role of second messenger. You know it's all G protein coupling system is there. Then another thing about these cholinesterase regenerators. You know certain nerve poisons or organophosphorus compounds, they inhibit the enzyme that acetylcholinesterase. So the cholinesterase. So there will be overactivity of the cholinergic system and the toxic effects will appear there. Next. Here is one classification given about the anticholinergic drug. Just see it down. The anti-muscarinic. And about the anti-muscarinic further division, M1 selective. This division is over here. These drugs are used elsewhere but not in USA. M1 selective. M1 selective, noted down. M1 selective. Well-known example is the pyrazipine. Pyrazipine. Another like that, it is the talenzipine. You will be shown later on. So it is M1 selective. Overall, when we say the M1 selective, it means the gastric acid secretion that will come down by the use of pyrazipine. In case of acid peptic disease, it may be helpful. Or where the other M1 receptors at other sites they are present, they will be blocked. Next is the non-selective antimuscarinics. So they will not only block the M1, they will also block the M2, M3 like that. When we say the anti-nicotinic, it means where lie the nicotinic receptors and how they are blocked. At the motor end plate, say neuromuscular blockers, tubocurarine. This is one alkaloid. You should be familiar with the alkaloid, the basic term alkaloid. So the neuromuscular end plate, these drugs will occupy so the transmission will be stopped. At that, these receptors at the neuromuscular blocking, they are known as the NM, note down, NM. And the nicotinic receptors present in the autonomic ganglia may be sympathetic or parasympathetic. These are blocked by one special group known as autonomic ganglia blockers. They are of historic importance, autonomic ganglia blockers. So prototype drugs is the hexamethone. In case of antimuscarinic, note down, again, it is the atropine which is prototype. You have been told that you can't be master of all the drugs. So you have to concentrate first on the main drug that is a prototype drug. Then the differences from it if they lie among the other members of that group. So in the anticholinergic drugs, another group is given the cholinesterase regenerators. You have been told about it. These are the oxymes. A well-known example, pralitoxin, very expensive drugs, and be given at the start of poisoning. So if there is delay, so it is known as aging. Note down aging. So permanent blockade of the enzyme. Antimuscarinics. Well, prototype drug you have been told it is the atropine. About the source of atropine, generally it is from Atropa belladonna. Atropa belladonna. Atropa. You have been told Atropa. This word is from Atropos, the goddess, some goddess of this fate and destiny. Atropos, goddesses. Atropine, goddess of fate. And belladonna means belladonna in Italy. This word was into Italy and in Spain. Belladonna means a beautiful lady. Belladonna. This is some history about it, atropine. This atropine is not only present in this Atropa belladonna. It is also present in another plant, that stramonium. Stramonium, that plant is the datura. In our Urdu is another datura. Datura stramonium. So it has got barbs, barb apple also known as barb apple. This is common. This is one local plant. And another source of atropine, that is, its sisters are there, hyoscine and hyoscyamine. Note on hyoscine and hyoscyamine. They are obtained from Solanaceae family. Solanaceae, niger, Solanaceae niger. So they are also a plant source, also known as galenicals. Next one about this atropine. The atropine. Pharmacological actions, you have been told it is non-selective. It not only it will block M1, it will act. This plant is seen here even in our own country. Is shown over here. Atropa belladonna, Solanaceae. Then you have been told, or rather, about this atropine tertiary mine, so it will cross the blood-brain barrier. It will have effect on the heart center. So some other drugs which are quaternary, so they just have effect in the periphery. And next, the duration of action is the 4 to 8 hours. Once the action is, this is atropine is given almost from all routes. It is given in, say, intravenously, it is given orally, so it is given parectally. It is also maybe applied as patches. So 4 to 8 hours, but in eye it has got very long effects that may remain for 2 to 3 days rather, duration of action. So for that very reason, because of its length, very long duration, so if at all in eye is certain other drugs which is shorter action, they are maybe from this group or from adrenergic drugs like tropicamide, that is anti-muscarinic anticholinergic. The effect is shorter. And then another drug is phenylephrine, alpha stimulant. So the effects on eye will be discussed here later on. Here you see a competitive blockade is there between the acetylcholine and the muscarinic receptor. They are blocked by atropine and scopolamine. Similar to scopolamine, also known as scopolamine nodone, it is hyoscine. So very simple, it's competitive. If you increase the dose of acetylcholine, so you can overcome the effect of atropine or scopolamine. It is competitive antagonism. This antagonism is a very common question in your Vivabosi. These are the general effects. Summary is given over here. Say the CNS. You see over here, there is sedation. Not only sedation, in say the higher doses, there may be other excitation, there may be delirium, there may be hallucination rather. So sedation is especially with the hyoscine, nodone with the hyoscine. Atropine may rather stimulate and then sedate. The other effect on CNS, the anti-motion sickness section. Anti-motion sickness, well-known drug for this anti-motion sickness is the hyoscine, noted on hyoscine. Then some of the drugs of this group, the anti-muscarinic anticholinergic, they are used in Parkinson's. Some of the parts of this of Parkinson, and they are helpful. So special drugs from this group like penstropine. So that is one. Also, another drug is you will see later on. So atropine, it has got amnesic effect, nodone, amnesia. So given before surgery, amnesia. There may be delirium, there may be a rather hallucination. So for recreation purpose may be used but dangerous. Hallucination. An effect on the eye, they will be studied later over here, that they have got very good importance. There is cycloplegia, loss of accommodation, and mydriasis. In case of atropine, it is the maximum dilatation. Maximum dilatation. So antidote over the here as in general, it is note down physostigmine and pilocarpine. Note down physostigmine, pilocarpine. Then effects on the bronchi. If the constriction is due to cholinergic drug, then atropine-like drugs are helpful. In bronchi, the bronchodilation will be there. So well-known drug used for inhalation is the ipratropium. Ipratropium, it is inhaled. So if the constriction is due to cholinergic system, the atropine and like drugs, they are helpful. The effects on the GIT and the genitourinary system, they are mostly similar. In the GIT system, there will be relaxation, of the smooth muscle. Peristalsis will be suppressed. They may be suppressed to the extent of, say, what is known as paralytic ileus. Paralytic ileus. Overall, the ileum that paralyzes. So another effect on this genitourinary salivation. Salivation, note down, it is the first effect. This dryness of mouth is the first effect of the atropine and the related drugs. Suppression of salivation. There will be dryness of mouth. Then effects on the genitourinary system. So there is relaxation of the bladder, but at the same time the sphincter they constrict. So there will be maybe urinary retention, and this is something very important in case of Bph. Note on Bph. What is Bph? So this is Bph, prostatic hyperplasia, benign prostatic Bph, note down. Effect on the heart, they are well studied. Initiators bradycardia, then in the heart the M2 receptors are there. So the blockade may result later on, and then there will be tachycardia. It will be taught to some extent, to some detail here afterward. The blood vessels, if there is dilatation of blood vessel due to the muscarinic drugs, so that will be counteracted. Not manifest unless a muscarinic agonist is present. Then effects overall on the glands. When we talk about the glands, the lacrimal glands, salivary glands, bronchial glands of bronchitis, mucus secretions, sweat glands. So note on effect of the atropine on the glands. If you recall the effects of acetylcholine, it would be opposite to that. So there is reduction of these secretions of these. So there will be more reduction of salivation. The salivation is the first thing which is suppressed with the atropine and the cholinergic. Then after the salivation, the next one is the lacrimation. Then say in case of coryza, lacrimation is there, or some other irritant is there and lacrimation is there, or this rhinorrhea, this allergy type condition, so lacrimation can be spread. Then sweating, lacrimation and sweating. The less affected glands, which are the gastric secretion. The skeletal muscles in normal doses, their activity is not suppressed. Skeletal. Then some detail of atropine on heart. Here you see something very important at the level of SA node. So at SA node it is biphasic action. At low doses there is initial bradycardia, note down, due to blockade of pre-junctional M1 receptors. Please note it down, something very important. At low doses the pre-junctional M1 receptors, they are blocked, and so there will be initial bradycardia. And moderate to high doses, there will be tachycardia. It means the M2 muscarinic receptor, they are blocked. Then effect at the site of AV node. So the PR interval that is reduced at the AV node, PR interval is reduced, and toxic concentration can cause intraventricular conduction block. Toxic, note down. These are the toxic doses. That has been attributed to a local anesthetic action. Local anesthetic action. This is very important. So why the block is there is written over here as it is a local effect. Clinical application studied earlier. Chris, on the CNS, motion sickness, you happen to know about scopolamine. Note down its other name, hyoscine. Note down please, hyoscine. Then the drugs for Parkinsonism, you know the characteristics of Parkinsonism, akinesia, dyskinesia, tremors, rigidity, like that. So it is of some help as adjunct in certain cases. The drugs which are given among these anti-muscarinic anticholinergic drugs, these are typical drugs. Benztropine, this is clinical classification, drugs for Parkinsonism. Benztropine. Then biparidine, trihexyphenidyl, orphanadrine. Note down this orphanadrine, please. Orphanadrine. It is not only given because of its atropine-like effects, it is H1 receptor by antihistamine. Another drug for Parkinson, procyclidine. Then after that, the third use is the acute dystonia. Dystonia. It is this if this dystonia is due to the giving of antipsychotic drugs, note down antipsychotic drugs, also known as major tranquilizers, antipsychotics, also known. So given the drug given for that acute dystonia, so it is the benztropine, also given in case of Parkinson. Effect on the eye, it must be studied in detail. There is mid-race, as you know, there are circular muscles, there are radial muscles. So the effect of these atropine light is on the circular muscle, then the radial muscle, they show their dominance, so there will be dilatation. Another clinical application in case of eye, it is to contract and then relax if there is corneal adhesions. So we draw pupil is constricted, pupil is dilated like that, so those adhesions may be broken down. Then in case of eye, you have been rather earlier told that in eye the atropine effect remains for 72 hours. So the short-acting drugs are better applied like homatropine, cyclopentolate, and tropicamide. If you need a drug for a shorter period, then you can give tropicamide, note on tropicamide. And one adrenergic drug is also there, say phenylephrine, that acts on the adrenergic receptors present in the radial muscles of eye. Why tropicamide is preferred over atropine? You have already been told about it. So then, because tropicamide short-acting duration of action in case of atropine is very long, 72 hours, and in case of tropicamide it is just half to 4 hours. Clinical uses in case of bronchi and the broncho in case of asthma. So what the effect will be there? The airway secretion, they will get dry. So there will be dryness of chest, note on dryness of chest. To avoid, secretion in case you give general anesthesia, so atropine is among the pre-medication. Note this word, pre-medication, pre-medication. Then about the asthma. In asthma, these drugs are inhaled, well-known drugs. They are ipratropium, have got local effect, tiotropium. Then in another indication is in case of COPD, chronic obstructive pulmonary disorder or disease is there. Aclidinium is given. Aclidinium is a new drug, aclidinium. Then effect on the GIT. So in case of, say, APD, what is APD? Acid peptic disease. So these drugs are tried, but not in US, pyrazipine for M1 blockade as telanzipine. If there is a smooth muscle spasm, so this atropine, very in small doses, it is spasmolytic. So the atropine is spasmolytic, hyoscine is dicyclomine. Say I've got, in colics you can give them, in colics. In case of bladder, if there is mild cystitis or there is bladder spasm after urologic surgery, so what the drugs are given in case that to avoid this and to avoid that passing of water again and again, to avoid the pain, the bladder spasm, oxybutinin. This is one MCQ type question, oxybutinin and tolterodine. Next indication, previously this atropine is given for, say, the bedwetting, to avoid bedwetting among the children. Stress incontinence, another condition in case of blood genitourinary tract indications. Stress incontinence. So tolterodine again is there, and some other drugs are. You have to concentrate, say, on tolterodine. Well, the next one. Clinical use, cholinesterase intoxication. It is another indication of atropine. So is drug initially, for the muscarinic effects of that irreversible anticholinergics, the nerve gases are the organophosphorus compound. Atropine is given in small doses repeatedly up to, say, 3 milligram at the most. So given repeatedly atropine. So the first effect that will appear, there will be dryness of the salivation. Salivation will be suppressed. Toxic effect, not only the toxic effects you will study over here in this pharmacology is so well known, mnemonic is there to talk about the toxic effects. So if the high doses, there will be dryness, overall dryness of the body secretions. So person will be dry as a bone, hot as a hair. Beautiful picture is given by Dr. Pracha. She is specialist in designing these slides. So blind as a bat, blind. So there people that dilate maximum, so that vision will be hampered. So red as a beet, the beet known as chukandar. So one is red as a beet and mad as a hatter. mad as a hatter. So these are one mnemonic may be given verbs. So you must, you will study this also in toxicology of your certain other effects given over hyperthermia. It is something very important in case of infant hyperthermia. It is not malignant hyper, it is just hyperthermia, also atropine. You have to be very careful in case of children while given atropine or atropine-like drugs. So there will be salivation is suppressed, lacrimation is suppressed, and sweating. You have been earlier told about it. There will be blurred vision, and mind that in case of acute angle glaucoma, acute angle cholangioglaucoma, there is contraindication. Note down. Acute angle. Other toxic effects there are constipation, maybe urinary retention, and another one on the heart. There may be tachycardia, there may be arrhythmias, very ventricular arrhythmias may be there, fibrillations. Then other is sedation. Not only sedation, there may be other rather hallucination, conversion, delirium, amnesia, and other toxic effect known as the atropine flush of the upper part of the body. There is flushing redness. As this picture is given again, it all you have been told about it earlier. Toxidrome, anticholinergic toxidrome. Talk what the tox effect will be there. Then dose-dependent effects. As the dose is increasing, so the effects given on right side, they will go on increasing. Next one. How to treat this toxicity? One is the symptomatic. So some symptomatic. You have to treat, blood pressure and the vital signs you have to maintain. Then severe tachycardia may be managed by given physostigmine. Physostigmine also tertiary, so it is helpful. So small doses of physostigmine. Then hyperthermia, to deal with hyperthermia, it is the with the cooling blankets or to evaporative cooling. Where not to give this atropine and light drug. This is the hyperthermia in case of children, acute angle glaucoma, Bph. Then about the therapeutic classification again, drugs for eye, long-acting atropine, short-acting homatropine, tropicamide. Drugs used alternately with miotics to break corneal adhesion, homatropine, tropicamide. Then drugs for motion, it is again the clinical classification. For motion sickness, hyoscine or scopolamine is the drug of choice. It is repetition. Then for bronchial asthma, ipratropium, tiotropium. The antispasmodic effects are of the atropine, hyoscine, glycopyrrolate. Another use you have been told about atropine, it is pre-anesthetic medication. In case of organophosphorus poisoning, atropine initially given, then oximes are given later, side by side. Oximes, not down, prelitoxin, oximes are the regenerator of the enzyme. Overdoses of physostigmine, atropine is indicated. Then, if there is overactivity of urinary bladder, then tolterodine already discussed. Then for APD, olanzapine. Then going through the therapeutic classification again. For Parkinson's disease, you have been told about benztropine, piperazine. For heart block is something also very important. Second and third degree heart block, symptomatic bradycardia can be treated with atropine. given parentally. Second and third degree heart block, something. Then drugs used in labor to produce twilight sleep with morphine. It is hyoscine. Hyoscine is depressant from very beginning. Then drugs with anticholinergic activity. I mean, you have been told that certain number of other drugs they have got this anticholinergic and anti-muscarinic anticholinergic effect, like the antihistamine or phenadine, diphenhydramine, tricyclic antidepressant, drugs for depression, imipramine, tricyclic amitriptyline. Then phenothiazine, they also have the antimuscarinic, like the chlorpromazine, thioridazine. Well, after that, there are certain MCQ you have to go through it, please. And it is all about it. Certain MCQs are there. You can't one, two, three, four, study it again and again. I have seen the students who go through MCQs given at the end of your uh, small catching, so they can easily go through the exam. Five, and I say it is somewhat lengthy to be discussed. Thank you very much. Hope you will concentrate on these uh, basic basic topics and you will be very successful inshallah. Thank you very much.